Good morning, my name is Sebastiano Mercadante. I'm director of the Pain and Supportive Care Unit and the Hospice and Anesthetics at La Maddalena Cancer Center in Palermo, Italy. There are many different conditions that may produce pain in patients with cancer. Some pain is dependent on the cancer itself, but there are some other circumstances in which pain is not directly due to cancer. For example, there are many syndromes that are produced by the treatment. For example, chemotherapy, radiotherapy, surgery. There is also a small group in which we have comorbidities of pre-existing pain condition, particularly articular disease, especially in older patients or diabetes. The principal syndromes regards, of course, different pain mechanism because we can have damages to the nerves for invasion or due to the progression of disease and the compression to some nerves or ganglions, for example. Or you can have involvement of the bone. In this case, you have nociceptive pain. There are other syndromes that in which we have the involvement of the viscera. For example, all the abdominal cancer produce a visceral pain. So we have a series of syndromes that are quite different, but the most common feature is the mixed pain syndrome, in which we have the presence of neuropathic pain and also nociceptive pain. Patient should be assessed. It's mandatory to assess patient, otherwise we cannot understand what thinks our enemy, that is pain in these cases. A real assessment may be simple, for example, by using the so-called numerical scale. Is very, very simple because it's a scale from 0 to 10, the maximum pain you can imagine, and 0 is no pain. But it's a really simplistic approach because pain is complex. First, we have to establish also the possible difficulties in treating this pain. So we have a different scale or method or tools that have been elaborated in time, starting from the Edmonton prognosis tool, including also the cancer pain prognosis scale, in which we have different items that can be considered a negative prognostic factors. In literature, we have different negative prognostic factors that include, for example, the presence of neuropathic pain, the use of large doses of opioids, that means a high level of tolerance, the presence of psychological distress, for example, and again, another problem is due to the presence to the diagnosis of an aberrant behavior. Such factors may condition our treatment because decrease the response to analgesics. But I have to say that the modern approach in terms of assessment should be highly individualized. It's important to understand exactly the profile of our patients, also in terms of expectations. In the last decade, several guidelines and recommendations have been produced in literature. There are the ASCO guidelines, there are the ESMO guidelines, and there are the AAPC guidelines. Of course, they have a different pattern according to the population, oncologist, for example, or palliative care physician. Generally, they suggest to use typically a sequence of drugs with the different potencies, according to the WHO recommendation, suggesting that anti-inflammatory drugs or non-opioids should be started first, followed by the so-called step 2 drugs, that means the so-called weak opioids, and at the third level, the use of strong opioids. However, I have to say that it is really obsolete to use these differences between weak and strong opioids, as strong opioids can be used at low doses and can be used as a second step drugs. This is a simplistic approach, of course, because we know that in clinical practice we will have completely different conditions. So there are general suggestions, but again, we need more knowledge and experience in the use of drugs, because the effect produced as analgesia in our patient, it depends on the operator, on the prescriber. The cornerstone of cancer pain management are opioids. No doubt about that, despite the opioid crisis in USA, opioid drugs are still the cornerstone of pain management. We have several drugs available now, at least in the developed countries. So we have to choose the drugs according to typical conditions. So guidelines are relevant, are important from the educational point of view, but at the very end, you have to have a profound knowledge about the use of opioids to individualize and to personalize the treatment in cancer patients. Opioid titration is a delicate phase, because when we start opioids in a patient who is opioid naive, this will be fundamental to improve the compliance of the patient. If patient receive inappropriate dosing, of course, they will lose the compliance and probably will stop the treatment. Opioid dose should be tailored for the individual patient needs. Potentially, we can have different scenarios. The first is, for example, patients who never received opioids. That means that are naive. In these cases, we have to use very, very slow doses that should be titrated according against the pain intensity until pain control is achieved, potentially preventing or treating possible adverse effects that can develop during opioid titration. The second scenario is that of a patient who are already receiving opioids. For example, weak opioids or low doses of strong opioids. Generally, this class of patient should be started with about 60 milligrams of oral morphine equivalent, and then titrating again the doses according to the effects. Another group of patients is represented by patients who are receiving chronic opioid therapy, but for different reasons. For example, the development of tolerance or the progression of disease have to increase their opioid doses. In these cases, it is suggested to increase 30-50% of the dose to achieve again analgesia. But it's relevant to reassess the patient, because we can have more and more causes of increasing pain. So we have to reassess this patient for the causes of pain and for the response to the single opioids that has been started first. One problem is when patients are receiving high doses of patient. These are patients at risk for developing adverse effects or to develop, for example, a sort of hyperalgesia induced by opioids. Again, it's important to reassess the patient for this condition, potentially to thinking about changing the opioids that is not effective anymore. One, the syndrome is not responsive to the single opioids because analgesia is not achieved despite increasing doses, or when a patient develops adverse effect which prevent any other further dose increases. Of course, the choice should be based on changing the opioids because the offending drugs is not useful for our condition. So experience has suggested that changing the opioid, switching to another drugs, which is potentially similar but is completely different from the pharmacokinetic point of view and from for other reasons, based on a rationale. The principal rationale is the asymmetric tolerance existing between opioids, particularly when using methadone as a second opioid. The principal problem is the conversion ratio to be used when switching from one drug to another one.
Hello, my name is Professor Mary Fallon. I'm Chair of Palliative Medicine at the University of Edinburgh, and I lead the Palliative and Supportive Care Group, which is a research group embedded within the clinical practice in the Edinburgh Cancer Centre and Western General Hospital. The common side effects of opioids that occur when one initiates opioid medication, or sometimes when one increases dose, are dry mouth, constipation, sedation, nausea and vomiting. We know that tolerance does tend to develop to sedation and nausea and vomiting over the first few days. And these should not be significant. It should be a subjective sedation, perhaps a bit of blunting of attention, and the nausea should be transient. Vomiting is less usual than nausea. If sedation and nausea and vomiting do not actually disappear after 2 days on opioids, one should be thinking about reviewing the entire situation. And we'll come to that later on in assessment. There are rarer adverse events with opioids, and we very rarely see respiratory depression in chronic cancer pain management, where there's rarely a sudden increase in dose or a sudden introduction to a large dose. The impact of side effects on a patient's quality of life is absolutely critical. And I think often in clinical practice, we underestimate the impact of the side effect profile. And at every assessment, which is absolutely key in achieving optimal pain management without a burden of side effects, there has to be very careful consideration given to all the common side effects. And one would expect ongoing problems with dry mouth, which will need proactive management, particularly if on other drugs causing dry mouth, and of course proactive management of constipation, unless in the rarer situations where patients have a background of genuine diarrhea. This comes down to a very careful assessment of the patient. at that initial consult where one is considering introduction of opioids. There are certain comorbidities that will immediately put a patient at increased risk of opioid-induced side effects. A very obvious one is renal impairment, as the vast majority of opioids are excreted renally. Patients with COPD, one has to take care, and clearly because of a potential for respiratory side effects, although there is an increasing literature on this and just a very careful considered titration, one can usually get a balance. Clearly a comorbid bowel, particularly where the susceptibility to constipation. This is, of course, very challenging for some patients, and one has to be very proactive when presented with this. So there are a number of comorbidities. Of course, from the point of view of the common troublesome comorbidity, particularly at initiation, is the cognitive blunting. And this will be exacerbated by other drugs. We know from systematic reviews that co-prescription of adjuvant analgesics will increase side effect profile of opioids. And not only can one have cognitive blunting, but actually frank confusion. And this is obviously something that we want to avoid. So we have to be very careful when considering other medications that the patient may be on. One of the common problems in palliative care is that patients often accumulate drugs like benzodiazepines prescribed often inappropriately because the patient's unable to sleep well, perhaps because of pain. And these, of course, will attenuate the ability to prescribe opioids without adverse side effects, particularly the cognitive blunting. So the complete assessment of the patient, and it goes without saying, if one is presented with a patient who already has cognitive blunting, then there has to be extra care given to the prescription of analgesia, and in particular the reassessment of that analgesia from the point of view of wanted effects, pain relief, and unwanted effects. So it goes without saying that fundamental to this is screening. We need good screening at baseline for any problems which might actually lead to opioid-induced side effects, such as slight cognitive blunting, renal dysfunction. And of course, we need adequate, regular, ongoing screening. And the patient and family also need to be part of this screening. They need to know and understand what we're looking for. In particular, the side effects that should really prompt us to reduce the dose are the CNS toxicities. In particular, a complaint by the patient that they're feeling a little bit impaired cognitively, their concentration is blunted, and of course frank problems like visual hallucinations, and even an increase in vivid dreams, which can herald subsequent hallucinations. So these should really prompt us to consider a dose reduction. And of course, a review of the patient, their blood work, and of course, other drugs that may be exacerbating these CNS toxicities, such as the adjuvant analgesics. Sometimes it's not enough to reduce dose, and in fact, we actually have to consider switching opioids. An example of this might be from an oral opioid such as morphine to transdermal opioid in an attempt to try and improve constipation. Another example is a change in renal function where we want to switch from a drug like morphine to, for example, transdermal fentanyl or transdermal buprenorphine, which isn't actually excreted by the kidneys. So there are a number of reasons to actually switch. So one should consider in the first instance dose reductions, reviewing all drugs and in particular adjuvant analgesics as well. But then with individual patients, considering a switch in an attempt to get a better profile between wanted effects, analgesia, and unwanted effects. So there are clearly a number of therapeutic options which can be considered to use opioid-induced side effects. So if we look at the common troublesome side effects for patients on a day-to-day basis, constipation is obviously high on the list, and we commonly prescribe a combination of stimulant and stool softener laxative to try and prevent opioid-induced constipation. So it's usually prescribed when the opioid is first prescribed, and the dose is titrated according to needs in an individual patient. Sometimes the use of a laxative, standard laxatives by themselves are not adequate, and even switching opioids doesn't make much of an impact. And we do, of course, now have the peripherally acting mu opioid receptor antagonists, which can be very effective in persistent opioid-induced constipation. It's always important to look at newer methods of pain control. And I think it's important to say that these include both pharmacological and non-pharmacological. From the point of view of adjuvant analgesics, in the last years we have had newer antidepressants such as duloxetine. We've had the newer anticonvulsants such as gabapentin and pregabalin. But of course, none of these adjuvant analgesics is a panacea for any particular pain, and they're commonly prescribed, of course, for pain with a significant neuropathic component. They have their adverse events. In particular, we want to look at the common troublesome ones, and drowsiness does occur with in particular the gabapentin and pregabalin at higher doses and cognitive blunting. It's not uncommon, particularly in older patients, to actually see that the introduction of even the newer anticonvulsants can in fact cause cognitive blunting and confusion. And of course, duloxetine, while commonly it does not cause sedation, that's unusual. It does actually have, of course, the standard anticholinergic effects. And of course, there are potential drug interactions, particularly with some of the tumoricidal treatments, for example, hormonal management of breast cancer, such as tamoxifen. So all of these drugs have to be considered with care, and we do know that they will exacerbate side effect profile of opioids when introduced. It is, of course, useful to consider any opioid formulation that has an inbuilt mechanism of improving side effect profile. And the combination of oxycodone and naloxone is a nice example of that for the prevention of opioid-induced constipation.
My name is Frank Elsner. It's a German name. And I work at the University Hospital in RWTH Aachen University in Aachen. It's a city in the western part of Germany, and I work here as a physician in the Department of Palliative Care. I'm also board certified as a pain specialist and palliative care doctor, but my former affiliation was to the Department of Anesthesiology, so I'm also a trained anesthesiologist. But I think that the most important thing when using opioids in a patient in pain is that you clarify what the reason for the pain really is. So we have 4 dimensions following the concept of Cicely Saunders for total pain, where we have one level on a somatic side, then a psychological, social, and spiritual influence on the existence of pain. So if we are sure that pain is deriving from a somatic part, then we can indicate and use opioids. So the indication has to be correct. If the indication is correct, then one of the most important parts has been fulfilled in the treatment or in the allowance of the use of opioids for cancer patients. And of course, if you have in mind a long-term opioid use, you also have to always, like in any other treatment as well, you have to think about risk and benefits, and you have to find a good balance where maybe risks are in the foreground or benefits. And of course, you try to get benefits on the top. And so you also, if the one part is the side of the doctors, but the other part is the side of the patient and the family. So that means that if you have the right indication, the next part is that you have to communicate the indication and what you want to use opioids, maybe also on long term, that you have to communicate the risks and benefit with the patient so that they know what they have to expect. That they know that there may be risks, that most of the risks, if the indication is correct, will not really occur or only occur in the beginning, that maybe constipation will last a bit longer but can be well treated. This is also, of course, an important message for the family and the caregivers. And if you have any idea of something in the background of the patient, like using alcohol or sedating medication over the counter or also prescribed by a doctor, another doctor, then you have to be a bit more careful about what you are doing. But I think if all these points are in your mind, then you can start with good conscience an opioid treatment. I think what would be helpful is assessment tool to assess the risks and the benefits of the use of opioids in an individual patient. Like at the first question, I refer to the background, the individual background of the patients. And so if you have a history of alcohol abuse, for instance, or drug abuse, or if a person is smoking, even adipositas means an individual risk when using opioids in terms of becoming addictive. So this should be in the doctor's mind when he's assessing the patient for beginning of a opioid treatment. And the question is how should clinicians evaluate the benefits and harms with continued opioid treatment? They should do this regularly, definitely, at patient visits or telephone calls, or even if patients, of course, are on your ward. So outpatient, inpatient, no matter, there has to be a regular visit and a regular assessment of potential abuse and potential risk factors that you may see. Sometimes these risk factors may also develop within a treatment trajectory, so that in the beginning maybe they have not been there, but then they come because of also the severeness of the illness of the patient, and then maybe he becomes slowly alcohol addictive, for instance, and you have to realize this as a doctor. And so you have again and again review also your prescription drug. And what you could also use, what they have in pharmacies, is monitoring, program data management, so where they can show you where you are on a high risk when you have a certain combination of medication, for instance, opioid with benzodiazepines, which may summarize the effect of sedation. And this may be a risk factor. So you have to discover this as a doctor. Then in the end, if you are aware of all the risks, then you have to reassess how to go on with your opioid treatment. I think the identification of these patients should refer to these 6 points which are likely to be occurred in patients with drug abuse: daily smoking, daily alcohol use, illegal drug abuse, long-term intake of benzodiazepines, long-term intake of benzodiazepine similar medication, and also the fact that the patient has adipositas may qualify to abuse, also opioid abuse characteristics. And if you only fulfill 2 of these mentioned 6 characteristics, and you are, in terms of the fact that you have chronic pain, you are a long-term opioid user, then in one study, there was 23% of the patients also fulfilling 2 of these 6 characteristics. In comparison to another population where in the study where there was also long-term use of analgesics, but not opioids in chronic pain, and there only 12% of the population fulfilled 2 of 6 of these mentioned characteristics. So whether it is causality or coincidence, I don't know, but fact is that if you are on a long-term use of opiates, obviously following this study, you are more likely to have 2 of 6 typical characteristics for being a potential abuser. I think this is quite interesting. And so I think it's important to have these 6 characteristics in mind to identify potential opioid abusers. What you have to do is to ask the patient how the medication really works. And sometimes it's difficult for the patient to describe the individual outcome of the treatment plan, and especially of the opioid effect. So you also have to monitor the use of on-demand medication, because normally you have a basis medication for the long-term treatment with opiates, but also the patient should have the possibility to refer to an on-demand medication, which normally is in a certain relation to the background medication of opiates. And the assessment of a potential reduce of opioids can also be judged by the use or not use and the amount of on-demand medication. For instance, if a patient does not use any on-demand medication and maybe is also describing an increasing sedation, this might be a hint for the fact that maybe there is, for what reason ever, now no longer the need for such a high dose, however high it is, of opiates. And then you could also think of a reduction of the amount of an opioid. And discontinuation in the context of palliative care patients normally, or the potence to discontinuate an opioid treatment in cancer patients in the context of palliative care normally is not expected, because of the fact that the reason for the pain on a somatic level normally does not vanish. But in certain cases, you may have situations where it can vanish. And For instance, if you have a bone metastasis and the bone metastasis crashes, and then the pressure which was there before may also decrease, and this may mean that the pain is going down, and this may mean if you have continuous opioid treatment at this time, that this may be relatively too high. And this could also qualify for instance, for a certain time of discontinuation or reduction of the opioid treatment.